Welcome to the Creative Commons RX podcast. Before diving into this episode, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
Okay, let's unpack this. When you think about daily medications, do you ever, stop to consider their secret lives? Not just how they help, but what happens when things go awry. Today, we're diving deep into a class of drugs that are literally lifesavers for millions of antihypertensives. We're not just looking at how they lower blood pressure, but their surprising toxicology, the hidden risks, and how their effects can sometimes be, well, an extreme exaggeration of what they're designed to do.
It's fascinating, isn't it, how far we've come? The journey of pharmacotherapy for hypertension really kicked off back in the 1960s. That was a crucial period when the undeniable link between high blood pressure and serious events like stroke and heart attack was, firmly established. This deep dive will trace the evolution of these agents from those foundational first-generation compounds to the newer, more targeted therapies we rely on today.
And our mission today is to give you a shortcut to being truly well-informed about these critical medications. We'll explore their mechanisms, what makes their toxic effects unique, often a very specific pattern of symptoms, what medical professionals call a toxidrome, and how an overdose is managed. You'll walk away with a profound understanding of these crucial drugs.
Yeah, and generally most antihypertensive toxicities are indeed an exaggeration of their intended effects, largely due to simply lowering blood pressure too much. But that's not the whole story, is it? What's crucial to understand really is that some classes, like centrally acting agents such as clonidine, they present truly distinct toxidromes that demand very specialized approaches. They don't just lower blood pressure, they create this unique constellation of symptoms that can be quite misleading.
Okay, so let's cast our minds back to those early days, the 1960s. We had, a handful of first-generation drugs, right?
Yeah.
Like centrally acting sympatholytics, direct vasodilators, diuretics too.
Exactly. Think of centrally acting sympatholytics like clonidine and methyl-dopa. Then you had direct vasodilators like hydralazine and minoxidil, and of course the various types of diuretics, thiazides, loop diuretics, potassium-sparing ones. These were the pioneers, you see.
Right. But then science marches on and we got these new and improved versions, right?
Yeah.
Promising better efficacy and, fewer side effects. What were those major breakthroughs?
Precisely. The landscape really changed with the introduction of beta blockers, then calcium channel blockers, and a particularly critical group, the ones that target the renin-angiotensin-aldosterone system, or RAAS, that includes the ACE inhibitors, ARBs, and the direct renin inhibitors. These truly reshaped hypertension management.
So when we talk about toxicity, is it generally just a case of too much of a good thing, or are there specific nuances to each class that, we should be aware of?
In many cases, yes, the primary clinical sign is an overwhelming degree of hypotension, just way too low blood pressure. But as we mentioned, some are truly distinct. Let's really unpack the most unique and, frankly, fascinating one first. Centrally acting sympatholytics. They're like the medical world's master of disguise, as you said.
Yeah, that's a great way to put it, because these aren't just about low blood pressure. They present a whole distinct profile, almost like a medical chameleon. What are the main culprits in this group?
Well, the primary agents here are clonidine, methyl-dopa, guanfacine, and guanabens. But here's a surprising fact. Even common over-the-counter imidazoline compounds, like oxymetazoline found in nasal decongestants, they can cause similar systemic effects if accidentally ingested. Think about that next time you reach for eye drops or a nasal spray. It's kind of sobering.
Wow. Now, what's fascinating about drugs like clonidine is that while they're maybe less used for routine hypertension today, they're seeing a huge surge in other applications. Why is that, and what are those new uses?
Absolutely. They're increasingly used for ADHD, attention deficit hyperactivity disorder,
Hmm.
also certain types of anesthesia, and as an adjunct in managing withdrawal from opioids, ethanol, nicotine. It's a broad and important range, but unfortunately, clonidine abuse is also a growing concern among opioid-dependent patients, which, adds another layer of risk.
And this expanded use, especially in settings outside traditional blood pressure management, it comes with a stark downside. Our sources tell us about significant toxicity, particularly for children. The numbers are quite striking: over 9,700 clonidine exposures reported to U.S. poison centers in 2014, with nearly 1 in 5 leading to moderate or major effects. That's truly concerning.
It is, and the hypotensive effects of these drugs are primarily due to stimulating those presynaptic adrenergic receptors in the brain. This effectively dials down the release of norepinephrine, that's your body's natural adrenaline. Imagine hitting the brakes on your entire sympathetic nervous system. That's how blood pressure plummets. This is key to understanding the distinct toxidrome we discussed. Interestingly, imidazoline binding sites also contribute to blood pressure lowering independently. It's complex.
Speaking of accidental exposures, the clonidine patches, they sound like a particular hazard, almost a hidden danger for families. What's the deal with those?
Yeah, they pose unique challenges, and this is a critical revelation from our sources. A single patch, even a used one, can contain far more drug than is delivered over a week. For instance, a zero point 0.1 milligram patch can have up to 2.5 milligrams of active drug still in it. Up to 70% can remain in the patch after use. So, puncturing or ingesting these, especially by toddlers who might find them, well, it can lead to rapid and severe toxicity. It's a powerful hidden danger hiding in plain sight in many homes.
So if a patient comes in after an overdose of one of these centrally acting sympatholytics, what does this master of disguise clinical picture look like? What are the key signs that make it so unique, almost, as you said, mimicking opioid poisoning?
Right. The signs and symptoms reflect an exaggeration of their pharmacologic action, but in a very specific pattern. You'll see significant CNS depression, that's central nervous system depression, ranging from just lethargy to profound coma. It can lead to slow, shallow breathing or even periodic apnea where breathing stops temporarily. Patients often experience bradycardia, a slow heart rate, in up to 50% of cases. And profound hypotension is the major cardiovascular manifestation. Even tiny ingestions like zero point 0.2 milligrams of clonidine can cause severe poisoning. And very commonly, you'll see meiosis or pinpoint pupils, which is precisely why it can be mistaken for opioid poisoning.
Ah, okay, so that's the link.
Exactly. And hypothermia, dangerously low body temperature, can also occur.
Given this striking similarity to opioid poisoning, the first thing many people, maybe even clinicians, might think of is naloxone. Does it actually play a role here?
That's a really important question, and it stems directly from that similarity, the CNS and respiratory depression, the meiosis. Now, while some patients, especially children, may experience increased arousal, better respiratory effort, heart rate, and blood pressure after naloxone, the reports on its efficacy are often, well, inconsistent, and the responses can be transient, sometimes just reflecting the natural ups and downs of the intoxication itself. You might need high doses, even 4 to 10 milligrams intravenously, and potentially redosing.
So what's the general clinical recommendation then? Is it a go-to treatment or more of a maybe?
Well, despite the lack of definitive controlled trials, an empirical trial of relatively high dose naloxone is considered reasonable if, and this is the key bit, if impending endotracheal intubation is a serious concern. So, if the respiratory depression is severe and isn't responding to just physical stimulation, however, and this is critical, this should never delay standard supportive air. Its most appropriate use might actually be to rule out or address unrecognized concomitant opioid toxicity, especially in overdose scenarios where multiple substances might be involved.
That makes a lot of sense. Okay, what about the flip side? Not an overdose, but abrupt withdrawal from these drugs. Does that present its own unique set of challenges?
It absolutely does. Abrupt cessation. Stopping these suddenly can cause a really dramatic withdrawal syndrome. You get excessive sympathetic activity. Patients can experience agitation, insomnia, tremor, palpitations, tachycardia, and severe hypertension, typically kicking in 16 to 48 hours after stopping. In really severe cases, ventricular tachycardia and even myocardial infarction, a heart attack can occur. It's like a complete rebound effect.
Wow. And here's a truly critical point our sources highlight. Certain medications are actually contraindicated in clonidine withdrawal. That's a powerful warning. Why is that the case?
This is a vital safety consideration. Beta-adrenergic antagonists, including common drugs like labetalol and esmolol, are explicitly contraindicated in clonidine withdrawal because they can dangerously exacerbate paradoxical hypertension. Basically, by blocking the beta receptors, they allow unopposed stimulation of the alpha-1 receptors, which can essentially unleash a hypertensive crisis. It's a situation where a drug typically used to lower blood pressure would do the exact opposite. Really dangerous.
Okay. The sources also touch on second-generation centrally acting agents like moxonidine and rolmenidine, and also dexmedetomidine. Are these similar to clonidine in their toxic profile?
They are related, yes, but generally more selective. Moxonidine and rolmenidine primarily target these I1 imidazoline binding sites with less affinity for the AD2 adrenergic receptors. This usually translates to a more favorable side effect profile and therapeutic use, less drowsiness, maybe. Dexmedetomidine, on the other hand, is a highly selective AD2 agonist. It's used primarily for sedation in clinical settings like ICUs, and in overdose, it presents very much like clonidine, sedation, meiosis, bradycardia, and hypotension.
And are there any special considerations for different patient groups when it comes to these drugs, particularly regarding accidental exposure or chronic use?
Yes, definitely. Infants and young children are particularly susceptible to systemic effects from topical imidazoline use, like in those eye drops or nasal sprays we mentioned. It's due to their smaller size and greater surface area to volume ratio. They just absorb relatively more. The elderly are also at increased risk of adverse effects, generally. And for pregnant patients, while therapeutic doses aren't usually linked to severe effects, clonidine does cross the placenta. And there are case reports raising concerns about potential birth defects. So the safest policy is generally to advise against imidazoline use during pregnancy.
Okay, so we've really deeply unpacked the unique story of centrally acting agents, especially clonidine, and their surprising master of disguise effects. Very interesting. But not all blood pressure medications work on the brain in that specific way, do they? What about other symptolytics, ones that affect the nervous system through different mechanisms?
Exactly. You have agents like guanethidine, guanidrol, and reserpine. These work differently. They reduce blood pressure by decreasing norepinephrine release from the nerve terminals themselves. Reserpine is particularly notable because it can deplete central catecholamines, those crucial brain chemicals. This can lead to significant CNS depression in overdoses, including drowsiness, hallucinations, or even profound depression. The main overdose manifestation, though, is severe orthostatic hypertension, where blood pressure just plummets when standing up, and this effect can be quite prolonged.
And what about the peripheral I1 adrenergic antagonists? How do they fit into this picture?
Right, these are drugs such as prazosin, terazosin, and doxazosin. They block IL-1 receptors primarily on vascular smooth muscle. This causes arterial relaxation and vasodilation, lowering blood pressure. While they're useful for hypertension and also for benign prostatic hyperplasia, or BPH overdose, can cause significant postural hypotension, just like razorpine, but also CNS depression and even priapism, that's prolonged painful erection. Management for both of these classes really focuses on supportive care, mostly IV fluids, and sometimes direct-acting vasopressors like phenylephrine if needed to get the blood pressure back up.
Well, let's talk about direct vasodilators. These were also part of that first generation of antihypertensives, right? And while effective, they certainly came with some significant adverse effects of their own.
They did. These drugs include hydralazine, minoxidil, and the infamous sodium nitroprusside. They primarily relax vascular smooth muscle, often by stimulating nitric oxide release. Now here's where it gets quite interesting. As this vasodilation occurs, the body's baroreceptor reflexes its natural pressure sensors remain intact. This means your body tries to compensate, leading to a reflex increase in heart rate and contractile force, basically tachycardia. The heart starts racing. Therapeutically, they're often used with beta blockers specifically to mitigate this reflex to stop the heart from going too fast.
And each of these seems to have its own unique gotcha, right? A specific side effect or risk that kind of sets it apart.
Absolutely. Hydralazine is famously associated with a lupus-like syndrome in chronic use, which is an autoimmune reaction. Minoxidil, people might know it better as Rogaine now, can cause changes on an ECG like ST segment depression. And there's an association with heart tissue damage at supertherapeutic doses. Interestingly, most recent exposures to this class actually involve topical minoxidil, often for hair growth, which just shows how even non-oral uses can have systemic risks if enough is absorbed or ingested.
But the real standout here, the one that comes with a truly built-in toxic package, is sodium nitroprusside. It sounds like a medication with a very serious downside if not managed precisely.
It really is. It's a prodrug, meaning it converts to its active form in the body. It releases nitric oxide, which is good for lowering blood pressure rapidly. But here's the critical detail. It also contains 5 cyanide radicals. Yes, cyanide. These are gradually released and can cause severe cyanide toxicity, especially with high infusion rates, prolonged use, or if the body's natural sulfur donor stores, which help detoxify it, are low. Signs include altered mental status, a specific type of blood acidity called anion gap metabolic acidosis, and in late stages, hemodynamic instability, basically, circulatory collapse. Very dangerous. Now, your body does detoxify cyanide into thiocyanate, but that can also accumulate, especially if there are kidney issues, leading to thiocyanate toxicity. Symptoms here are more nonspecific nausea, dizziness, confusion. But critically, thiocyanate toxicity does not cause that anion gap metabolic acidosis or hemodynamic instability,
Okay.
which is a key differentiator from the acute, life-threatening cyanide poisoning.
So how do you manage something as potentially serious as cyanide poisoning from a medication? That sounds, frankly, terrifying.
For cyanide toxicity from nitroprusside, prevention is absolutely key. Often this involves giving sodium thiosulfate along with the nitroprusside infusion to help the body detoxify the cyanide more effectively as it's released. If poisoning does occur, hydroxycobalamin is the current treatment of choice. It binds directly to cyanide. For thiocyanate toxicity, monitoring levels is important, and hemodialysis, that's a form of blood purification, is effective for clearing it from the system.
We've covered some really potent first-generation drugs there. Another cornerstone from that early era, and still incredibly common today, are diuretics. But their toxic effects seem to play out quite differently, don't they? It feels less about acute overdose and more about chronic imbalances over time.
That's a great observation. Yeah, unlike many other antihypertensives where acute overdose is the primary concern, the majority of diuretic toxicity is metabolic. It typically occurs during chronic therapy or, overuse rather than a distinct acute overdose, which is actually quite rare. The main issue is a disruption of the body's electrolyte balance: sodium, potassium, magnesium.
Right. So what are the most common metabolic abnormalities we should be aware of, and why are they so dangerous?
Well, you see things like hyponatremia, that's dangerously low sodium, especially common in older, malnourished women taking thiazides. And rapidly correcting this can lead to a devastating neurological injury called osmotic demyelination syndrome. So careful correction is key. Then there's hypokalemia, low potassium, and hypomagnesemia, low magnesium. These are really important because they can precipitate dangerous ventricular dysrhythmias like torsade de pointes, a chaotic heart rhythm that can lead to sudden death. Conversely, hyperkalemia, high potassium, can occur with the potassium-sparing diuretics like spironolactone. Hyperglycemia, or high blood sugar, is also associated with thiazide diuretics, possibly due to potassium depletion affecting insulin secretion. And finally, hyperuricemia, high uric acid, renal calculi, kidney stones, and gout attacks are also linked to thiazides. It's quite a list of potential metabolic issues.
And how do you manage an overdose, rare as it may be? Is it simply about correcting those imbalances?
Pretty much. Acute overdose management is primarily supportive care. It focuses on rapid assessment and correction of fluid and electrolyte status. The diuresis itself, the increased urine output, is usually short-lived, so the focus is really on managing the aftermath of those fluid and electrolyte shifts.
Okay, now let's shift gears into what many people probably think of as the more modern era of blood pressure medication, the RAAS inhibitors. These include ACEIs, ARBs, and DRIs. Let's start with ACE inhibitors. They're incredibly common: lisinopril, ramipril. How do they work, and what are their unique toxicities?
Right, ACEIs, or angiotensin-converting enzyme inhibitors, they inhibit the enzyme that converts angiotensin A6 to angiotensin II. Angiotensin II is a potent vasoconstrictor, so blocking its production leads to vasodilation and reduced blood pressure. But here's where it gets particularly interesting regarding side effects. They also elevate bradykinin concentrations, and this bradykinin is thought to be the primary cause of two significant and potentially severe adverse effects: angioedema, that's severe swelling, especially of the face and airway, which can be life-threatening,
Yeah, that sounds terrifying.
and a persistent chronic cough that affects a significant number of patients. Other concerns include hyperkalemia or high potassium levels.
That angioedema, especially the airway swelling, is a major concern. But there's an even more critical warning for pregnant individuals, isn't there? Surely this is widely known, but is it still sometimes missed? Or is it more about ensuring patients truly understand the absolute criticality of this warning?
You're absolutely right, it's critical. ACEIs are considered potential teratogens. They should never be used by pregnant women or women of childbearing potential who aren't using reliable contraception. The risk of severe birth defects, particularly affecting kidney development, is very real. While it's a well-known contraindication among healthcare providers, patient education and clear communication remain paramount. It's a stark reminder that even common medications can have profound impacts that must be carefully managed, especially during pregnancy.
What about overdose with ACEIs? Is it as dangerous as that angioedema risk sounds, or is it surprisingly maybe less severe than one might expect?
Interestingly, acute overdoses of ACEIs actually seem to have relatively limited toxicity. Fatalities are rarely reported in isolated ingestions, meaning just the ACEI alone. Many patients actually remain asymptomatic. When toxicity does occur, it's typically hypotension, low blood pressure. Management is supportive care, mainly fluids. Interestingly, naloxone has been explored, believe it or not, for reversing hypotensive effects.
Really? Naloxone again.
Yeah, the theory involves inhibiting enkephalin metabolism, but its role remains pretty unclear, not standard practice. And a potentially more promising new treatment for refractory hypotension, meaning blood pressure that just won't respond to usual treatments like fluids and pressors, is methylene blue. It seems to work by increasing mean arterial pressure and systemic vascular resistance. Still emerging, but interesting.
So if ACEIs are all about blocking the formation of angiotensin-second, what's the deal with ARBs, angiotensin receptor blockers? Do they work in a similar way, or do they approach the problem from a different angle?
They approach it differently. ARBs, like losartan, valsartan, they antagonize angiotensin II directly at its receptor, the AT1 receptor. So instead of preventing angiotensin II from being made, they effectively block its effects at the cellular level. They stop it from doing its job. This also blunts the sympathetic and renin-angiotensin systems, reducing blood pressure.
Do they have similar side effects then, especially that concerning angioedema? Is the risk the same?
They generally have a similar side effect profile to ACEIs, including hyperkalemia. Now, mechanistically, because they don't directly affect bradykinin breakdown as much, they should theoretically have a lower incidence of angioedema and cough, and often they do, but serious cases of angioedema have still been reported with ARBs, so the risk isn't zero. And critically, just like ACEIs, they are also considered potential teratogens and should be avoided in pregnancy due to the same serious risks to fetal development. That warning is just as strong.
And for overdose, is it similar to ACEIs? Perhaps not as acutely dangerous as one might initially assume?
Yes, overdoses are few and far between, and again, they primarily manifest as hypotension, if anything. Management is supportive with intravenous fluids and catecholamines like norepinephrine if needed to support blood pressure. And for that really tough refractory hypotension, similar to ACEIs, methylene blue is emerging as a potential treatment option. And vasopressin, another type of pressor, has also been reported to be effective in some cases of ARB overdose refractory hypotension.
Okay, finally in this group, the direct renin inhibitors, or DRIs. How do these fit into the whole RAS picture, and what makes them unique within this system?
DRIs, like aliskiren, are unique because they target the very beginning of the cascade. They directly inhibit circulating renin. Renin is the enzyme that starts the whole process by converting angiotensinogen to angiotensinohyde. This is different because while ACEIs and ARBs often cause a compensatory increase in renin levels, only DRIs can blunt the effects of this rise by hitting the system right at the start.
Are they generally safe in overdoses, and is there anything else particularly noteworthy about their use or risks?
Well, DRIs are generally considered to have limited toxicity in overdose. In fact, our sources state there are no reported cases of poisoning or overdose specifically involving them. Hypotension would be the anticipated effect if it occurred, and it would be managed supportively, just like with ACEIs and ARBs. However, this brings up an important point. There's a significant controversy surrounding their use in combination with ARBs or ACEIs, despite them all targeting the RAAS.
Oh, really? What's the controversy there? It seems almost counterintuitive to avoid combining drugs that work on the same pathway, especially if they might offer additive benefits.
It does seem counterintuitive, but it's a crucial safety consideration based on trial data. A major clinical trial involving patients with diabetes and chronic kidney disease who are receiving such combination therapy, a DRI plus an ACEI or ARB, was actually halted prematurely. The reason: there was an increased incidence of ischemic stroke, acute kidney injury, hyperkalemia, and hypertension in the combination group compared to those on single therapy. So it powerfully highlights that sometimes hitting the same system too hard from multiple angles isn't better, and combining multiple RAAS acting agents can lead to unexpected and severe adverse outcomes. A really important lesson.
Wow. So what does this all mean for us? We've journeyed through quite a landscape here. We've seen how antihypertensives, while incredibly vital, have these fascinating and sometimes alarming toxicological profiles. From clonidines' really strange opioid-mimicking effects to the terrifying potential for cyanide release from nitroprusside, and those subtle but dangerous metabolic quirks of diuretics. It's a whole world beyond just lowering blood pressure, isn't it?
Absolutely. If we connect this to the bigger picture, it's really about understanding that while most toxicities are, yes, an exaggeration of the intended effect, specific classes present profoundly unique challenges and these distinct toxidromes we talked about. The evolution of these drugs has brought improved efficacy, for sure, but also novel considerations like the teratogenicity of the RAAS inhibitors, which is huge, or those critical contraindications in clonidine withdrawal. It truly highlights just how precise and complex managing these medications can be and why understanding the nuances is so important.
It really hammers home how complex even seemingly common medications can be, and why understanding their precise mechanisms and, critically, their potential misfires or toxicities is so crucial, not just for medical professionals, but frankly for anyone taking these drugs or caring for someone who does.
Which leaves us with a final, maybe provocative thought for you, the listener. As we develop increasingly specific and powerful medications, drugs that interact with our body's intricate systems in ever more targeted ways, how do we balance their intended benefits with the potential for unexpected and complex toxicities, especially when multiple systems are involved, or when they interact in surprising, sometimes detrimental ways, like those combination therapy risks we just discussed?
Something to definitely mull over as you go about your day. Thank you so much for joining us on this deep dive into antihypertensive toxicology. We hope you feel a little more well-informed and perhaps just a little more curious about the medicines that shape our health.
This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.